contributed to this. As you know, there are very, very well-established practices. There are enough pilots done. There's enough work done. We don't really need to reinvent new pilots, new work. So if you see on the top, we have the patient activation, where how do we really do stress reduction, motivational interviewing, best practices from Stanford around self-management. On your right is the medication bundle protocol, Dr. Jim Diddle's bundle, and all phase Kaiser's and European guidelines. And on your left is the pharmacist in the care team. And as Liz said, 10 years back, no one believed that pharmacists could be an integral part of the team, but now pharmacists are essential part of the care team. So we have all the things which we need, the tools and resources to really move the needle to getting us to zero equation. So with that, the question I have for you is, if Brian, you can, what do you think? We have three areas, and we are not trying to regionalize, but this is more California, but we have three beautiful collaborators going on in San Diego, LA, and Sacramento. But we just want to get your polling. What do you think? We want to gauge in your systems, in your health plans, in your regions. Are you able to identify targeted population, track data, and report on patient-reported outcomes? And when I say patient-reported outcomes, I also mean major adverse cardiovascular events like heart attack, stroke, angina, other things. Wow, okay, very good. So I think most feel that they can track data. That's very nice. So now you have the data, and as we said, you can't improve anything. If you don't measure it, you can't improve it, right? Something similar to that. So the next slide is, do you think that your local health systems, or where you are part of, are ready to implement and sustain, and I think the key word is sustain, cardiovascular risk management programs? So the point is, when can we move from pilot to sustainable programs? Very good. I think we have a very optimistic group of people. Nice. So I think the last question is just as a food for thought. I think when you're thinking of this presentation and you're hearing our speakers here, just think about when we go back, when we look at this right care triangle, what should we do more for proactive screening for vulnerable population? And Dr. Wright, for example, this morning said, all the things, these are the population we need to focus on. What should we do doing more? Is there something we are missing? We should be doing more. So with that, I'll now turn it over to Dr. Ivey, who's going to speak on the analysis of the first demo project.
That must be Brian's helping me.
Okay.
So I can do this? All right, hi. So is everybody still awake? You know you're in trouble when you're coming up as the speaker and somebody at the table next to you said, I think I'm going to have to leave pretty soon. I'm just so tired. So wake up. There's cookies back there. There's water back there. So everybody can.
Coffee?
Yeah, coffee, tea, decaf. So my job is really to tee up for Dr. Fremont's big presentation. But what I wanted to do was go back and kind of review where we've been and what we've been doing and what the results were earlier on. Some of you might have been here about 1.5 years ago when we talked about these results that were at that time preliminary, and now they've gone on to be published. But we just want to re-describe again what the impact of California Right Care Initiative's university best practices have been on the hospitalization rates for acute myocardial infarction and stroke in San Diego County. So as you might remember, San Diego County was our first, hopefully I do this the right direction, our first university best practice. And this article has now been published looking at the countywide physician organization learning collaborative and the impact on these hospitalization rates. So the key aim was to reduce the incidence of heart attack and stroke in San Diego County. And the intervention started with some preliminary meetings with major medical groups in San Diego, followed by monthly meetings with medical directors, pharmacy directors, and quality improvement directors in order to share, I think I'm supposed to do that, best practices through collaborative learning, and for some people pulling out into a separate data sharing group that was also meeting monthly to look at their data together and look at changes that they were making related to key process and outcome goals. The San Diego project has included all the major delivery systems in that area, physician organizations, community clinics, and has treated patients from all payers, including commercial, Medicare, Medi-Cal, safety net clinics, the U.S. Navy, and U.S. Department of Veterans Affairs. And together, those providers provide about 80% of the care in San Diego County. Then we applied a method called difference in difference analysis to look at the change over time in hospitalizations after UBP began. Our data source was the statewide hospitalization data we call OSHPD, the Office of Statewide Health and Planning. And we used that data set from 2007 to 2014 to look at. Oops, what did I do there? All right. And so this is sort of the punchline there, is that if you look at the top set of lines, this is California's stroke hospitalization rate, and the dotted line is the state, and the solid line is San Diego County. And disappointingly so far, we weren't able to see really a difference in stroke hospitalizations with the implementation of Right Care Initiative's UBP in San Diego. However, if you look at the bottom line, which is acute myocardial infarction, we were able to use that difference in difference approach to look at these two lines diverging over time, showing that there was an impact of the changes going on at the county level, differentiating San Diego from the rest of the state. And that difference is about 13% over time. And that 13% represents about 2,700 saved acute myocardial infarctions. And so the next step was to look at this in comparison with the state rates, and then look at what would happen at the state level if we were able to make that same level of reduction across the state that we've been able to make in San Diego. And with a difference in about 13%, this turns into about 20,000 fewer acute myocardial infarctions over time. And that translates into a saving of about $450 million over that same time period. That's a lot of dough. So initially, Right Care Initiative's University of Best Practices in San Diego was associated with a lower hospitalization rate for acute myocardial infarctions, but we didn't see that same change for stroke. So that's like the glove getting thrown down again for us to buckle down and see if we can make those same kinds of changes for strokes. We know that there's the limitations, that there could be other things going on at a county level that we don't have in our analysis, but we did look at things like hospital openings, hospital closures. We looked at differences in coding, things like that, that might be other explanations, and concluded that it's plausible that the University of Best Practice made a contribution to this trend in San Diego County, and that we're doing better in San Diego County compared with the overall state trends. So the next step was to talk with Alan Fremont and say, can you add 2 more years of OSHPD data to this and do this again? Maybe UC Berkeley was wrong, maybe we leapt to too many conclusions. Can you just redo this again and help us see if the trend continues? So Alan's going to take us down that road next.
Thanks, Alan.
Do I need to switch slides?
He would do it.
All right, he's going to do that.
Good afternoon, and thank you for staying this time. And the awards are coming, and the cookies are really good. All right. So, as Susan was saying, part of what I'm going to talk about, or really mostly what I'm going to talk about, is an update on the analysis you were just looking at. And the update involved getting some newer data that wasn't available before. They had looked through 2014, we've extended out to 2016. And we're also trying to do, not necessarily a deeper dive, but a different look and try to make sure that the findings held up the original one they did and so forth. For the purposes of today, well, first I want you to note I have the requisite picture of the timekeeper. Originally, I thought I'd only have 5 minutes. But we're going to ask 3 questions, or we're going to look at that. What's the cumulative impact of the RCI, Be There San Diego regional collaborative so far? And I think, as most of you know, it started out as the right RCI collaborative, and then at about 2013, 2014, it shifted over to being called Be There. In addition to looking at the overall impact, we're going to look at, has the gains that we saw relative to California been maintained? One of the challenges is the finding you're seeing where there's potentially this association and impact. For a long time, when you've looked the research on regional collaboratives and so forth, aligning forces, whatever, even where there's been a lot of resources, it doesn't always show much impact. And so this association is really hopeful, but even when you can show some initial impact, sustaining that impact over time or the cost savings is often hard to do. So that's another thing we're going to look at. And then finally, we're going to take a quick look at have the changes been uniform over time. I'm going to just start out with the big reveal, which, so using the approach that, very similar to what Brent Fulton, Susan Ivey, and others had done, where we stand after 6 years is an estimated 3,800 hospitalizations saved in San Diego County. That translates into an estimated $86 million saved. If, hypothetically, we could wave a wand and have the same sort of pattern of trends and reduction throughout the whole state of California, or at least the rest of California, that would be 41,000 heart attacks avoided and $935 million saved. Earlier today, we saw a very compelling and impassioned presentation from someone who had experienced a stroke. What I want to take just a 10-second pause on, and for everyone in the room to get, and I know you all get this because most of you are clinicians, but each of those people, it's not just lives or dollars, it's the disruption, even if they survive, it causes in their own lives and in their families and so forth. So probably the cost or the impact or what it saved and made possible is even greater than those numbers suggest. So earlier today we heard about from Janet Wright that though we've had the steady decline in cardiovascular related deaths and disease, that we're starting to see a slowing. One of the things we may be seeing in California that we initially thought was an artifact, but it seems to be real, is throughout the state there is either flattening and there may be a genuine inflection up of the AMI hospitalization rates. With respect to the question of, is San Diego sort of maintaining that lead? The answer is yes, they are, in terms of, that is about a 22, in the two periods, the one that Susan was describing, what we're calling the early post period there, the average difference from that from the before period was about 22%. The average difference in later post is about 23%. And in fact, proportionally more of the AMIs, hospitalizations avoided, happened in those last few years. There are some other factors, which I'm not going to go into now, but we could get into the discussion if anyone's interested, in terms of at that 2014 period, there were some changes in heart attack coding. There's been some changes in the biomarker test used to identify AMIs. There's been change in the measures of LDL cholesterol. We've looked at all those factors, and so far we haven't found any compelling evidence that explains the uptick. So probably for right now, the takeaway is maybe it's a little bit of a leaky boat phenomenon or something, but our job is not done. So these are just sort of a summary of the numbers that you were seeing on the graph. Just for orientation, the one on the left, that's the total 6-year period. It was about a 22% reduction in San Diego, pre to post, or sort of on average, and then versus 7.6% in California. You can see in that second rectangular box, same sort of thing. If you compare just the last 2 years to the pre-period, it's also about it's 24%, slightly more greater than that. And that's a difference of about 27, 28 AMI hospitalizations. So as an example of the subgroup analysis, here you're looking at this is the two, well, let me kind of, so the first part is you're looking at the early period, 2011 through 2014, and the second is the last 2 years, 2015 through 2016. And remember that on that trend line, it was sort of 2014, 2015, and after that you start to see things go up. So let me kind of walk you through this. First, look at the purple bars on the early period, and those purple bars are San Diego. And what that is basically telling you is across, to the question of were the changes consistent, were they uniform across different age groups? The answer was in San Diego, it appears, there were reductions, sizable reductions in all 3 age groups, 18 to 44, 45 to 64, and 65 plus. In the rest of California, you did see a decrease in the elderly, or 65 and above, but really no change at all in those under 64. If you go over to this new period where the AMI rates are starting to trend up, you see that in San Diego, you still got these reductions. It actually increases in the older population, drops a little bit in the under 64, but still holding, and then it's starting to increase in it's probably, as Janet was saying, the 35 to 64 population. Okay, all right. Yep, that's it. And so here is, this is just some supporting sort of trends we're seeing in San Diego. This is what you're looking at. One of the components in San Diego, besides the University of Best Practices, or its complementary, is we have something called the Data for Quality Project. And this shows the blood pressure control rates, which the target has been 80% that we've been shooting for. This is the all-payer, all-group rate. And what you can see is we've, for both diabetics and hypertensives, the groups, the overall score is above the 80% mark, and that includes some FQHC, so it's pretty impressive. Here's an acknowledgement to other people who's been working on this, and we've got a paper in, so we're keeping our fingers crossed. Thanks.
Thank you, Alan. So I think next is Dr. Tony Ko from, you want to give your perspective from LA?
I'd like to just tee up this section a little bit. So as you saw in the numbers that Alan and Dr. Fremont and Dr. Ivey just presented, we, through managing LDL 100, cholesterol, blood pressure, and blood sugar, we were able to work the triangle of promising interventions to get more of the patients who were identified to be in good control. And so we were expecting, so our hypothesis going in with our NIH grant and with our first pilot project into San Diego was by managing those risk factors, we would drive down rates. And in fact, we did see that with a fairly intensive treatment. So my question today is a scientific question, which I'm hoping we'll be able to write a paper about, which is to say, if we did those things, which are just really the tip of the iceberg, what are the other components of the equation that would allow us to drive to zero preventable premature deaths and disabilities from cardiovascular events? So we have some of the leaders of our University Best Practices here together, Dr. Bill Baumer from UC Davis, and also from the American College of Cardiology, who studied physics undergrad, so he really loves my idea of creating an equation that actually puts a factor next to each one. How much of this is based on the LDL control? How much of it is based on the blood pressure control? How much of it is based on the blood sugar control? And we really loved the data that Janet Wright showed us, and we're sorry that she had to get called back to work in DC because she has a very good understanding of which of the components of the equation we've been working are driving down the events more. And one of our great puzzles, and we want everyone in this room to be thinking about this, is why are we driving down acute MIs, but we're not really driving down those strokes as much? And of all the brainiacs that work on this project that are in this room and outside of this room, we still don't have a good hypothesis of why that is. So we wanted to start the discussion that will hopefully end up in possibly a Delphi process, if Hector Rodriguez is willing to help us, or maybe Dr. Fremont. We wanted to start the discussion at the table here with Dr. Baumer from our Capital Region, Dr. Tony Kuo, who is with both UCLA and the LA Department of Public Health and helps us lead our Los Angeles work, as does Dr. Fremont, and Dr. Agnihotri, who first helped us kick off the Capital Region University of Best Practices as our initial co-chair there, and now is with the San Diego University Best Practices. So we've got a lot of great minds here to help work the equation, and we want you all to be thinking about those components. So let's start off with Dr. Baumer, who did create some slides with the help of our wonderful pre-med doctor. He will soon be a doctor, Brian Vong. Whichever medical school gets him will be very lucky.
Thank you very much for sticking around. I certainly appreciate it. It's not a sunny day here, so you're warm and protected in here. So settle down and we'll enjoy the rest of the afternoon. So the task here was getting to zero. So we're talking about how do we really optimize our healthcare and our provisions to get to zero health risk and zero events for the individuals that we're talking about. So this talk is going to be short because getting to zero also included the timer here as far as presentation. And we're going to talk a little bit about getting to zero for the phenotypes, that is the patients that we're dealing with. We'll talk a little bit about genotypes because we're all here and all individuals based on our genes. Considering costs as well, because we have to realize that getting to zero has to be cost effective for us. Talk about efforts that we have done in California and then Sacramento related to the Right Care Initiative. So getting to zero is pretty easy. If you look here, this is an equation to get to zero, and I put the first equation up from the Inner Heart Study. And the Inner Heart Study, Salem Youssef showed that if we look at the risk of cardiovascular disease, that is having a myocardial infarction, the odds risk for that is the following formula. Now, the constants that you see in front of each variable give us a priority of what's most effective. So I've ordered them in the list of most prioritized. So ApoB-A1 ratio is a lipid. So this is looking at dyslipidemia. So lipids are important, and if you have elevated lipids in this ratio, that's going to increase your odds of having a myocardial infarction by 3 times. Next in the order is smoking. So that's a highly significant variable and is almost as strong as cholesterol as far as our risk of a heart attack. And surprisingly, the next one is psychosocial stress. That is the stress of driving here today in traffic and getting through everything. And if you're in a stressful situation, we see that. Sacramento, we've identified a stressful group, the firefighters, and they're at anywhere from 3 to 10-fold increased risk of having a myocardial infarction. So we're working with that as well. The next is diabetes. We've talked here today about control of diabetes. That's a significant risk factor for myocardial infarction. Next in line, almost as much as diabetes, is hypertension. So control of hypertension, crucial in trying to get our risk down to zero for that. The next is abdominal obesity, and abdominal obesity increases cytokines, inflammatory markers that affect our vasculature throughout the body at that time. So reducing abdominal obesity, clearly a factor for that. The next I've shown in red because these are positives. We want to increase fruits and vegetables for that. If you don't have it, it increases your risk by 42%. But if you, in fact, have a diet rich in fruits and vegetables, then you can reduce the risk with that. Physical activity reduces the risk as well, so we want to encourage that. And moderate alcohol does 1 to 2 drinks a day for women and for male, does reduce the chance of myocardial infarction. In this Inner Heart trial, in 52 countries, every ethnic group was studied. And if you look at just these variables, it explains in women 94% of your attributable risk. If we can control those, we could remove 94% of the risk in women and 90% in men. So we can't get to zero with this, but we can get to under 10% risk at this point in time by eliminating each of the variables shown here. We have better data in the pooled cohort study. We participated in these trials, including CHS, and we were in those trials. Those have more sophisticated equations. I won't go into them because they're log, linear, and they're exponential log, and they're more complex, but they deal with the same things. If we can control cholesterol, control blood pressure, HDL is sometimes seen with metabolic syndrome associated with obesity. We can control those factors, they'll be the same. The simple one is seen from the Inner Heart study. We can get more complex ones, but it pretty much says control these variables and you can almost eliminate the risk for myocardial infarction for that. We know that there's non-significant variables that we've looked at. That is